12 years old male child. 12 years old male child, resident of Tokan Peak, presented to the tertiary care hospital in emergency department on 1 week, 10 days back, with the presenting complaint of fever from the last 7 days and body swellings from the last 5 days. My patient is a known case of chronic kidney disease with poor compliance and follow-up. According to the mother, he was in a usual state of health 7 days back when he developed fever. It was low grade, intermittent, more in the evening, not associated with rigors and chills, and relieved with syrup paracetamol. And it was associated with body swellings from the last 5 days. It was gradually in onset, initially involving the periorbital region, and then progressed to the abdomen as well as the bilateral feet with no diurnal variation. And it was not relieved with medications and urination. With these complaints, the patient was having shortness of breath as well as burning micturition and decreased urine output. However, there was no history of INA discharge, loose motion and vomiting, and jaundice, hematemesis amelina, and frothing in urine. He was investigated in the form of blood test, urine test, chest X-ray, ECG, and echo. And it was he was managed with the IV fluids, IV antibiotics, and 6 sessions of hemodialysis has been done since then now. And one time he has been also transfused with blood with no post-transfusion reaction noted. And the previous oral medications were continued in the same dose. Her current status is improved. Fever and shortness of breath has been settled. However, the swelling has also been settled, but not subsided completely. And no plan of discharge has been told to the patient yet. Actual history of the patient dates since birth, when the parents noted swelling at the back of the patient, for which they took it to the tertiary care hospital, and he was operated there. After that, the patient complained of urinary incontinence, and for which he was catheterized intermittently, but the patient lost follow-ups after that.
Okay.
2 months back, the patient 2 months back, the patient presented with the complaint of fever. 2 months back, the patient presented to the tertiary care hospital with the complaint of fever and decreased urine output along with burning micturition. The fever was low grade and intermittent, and it was also relieved with antipyretics like syrup paracetamol. And however, there was no history of loose motion and vomiting at that time. Also, shortness of breath and palpitation was not there, and body swellings were also not present at that time. Prior to this disease illness, the antenatal scans of the patient were normal. However, mother has told about the not taking folic acid tablets during the pregnancy, and there is no history of drug intake, and also alopecia. There is no history of alopecia, oral ulcers, and body swellings, and a poor urinary stream, and passage of gravels in urine, and polyuria and polyuria and failure to thrive, polyuria and polydipsia, and renal disease, as well as disease of the hearing is not present in the family. He was a complete workup was done in the tertiary care hospital, and the mother was told about the kidney problem at that time. And at that time also, he was managed with 3 sessions of dialysis, because before he was admitted for 1 week in there. And after that, he was discharged on regular dialysis session 2 to 3 times in a week, along with oral medications, vitamin D supplementation, phosphate binders, and antihypertensive. But the patient and hemodialysis sessions, hemodialysis occurs through central venous catheter line. Here, the patient was being told about the fistula making, but no proper instructions were given. And after that, the dialysis sessions were eventless, and also the injection was also given at the subcutaneous injection was also given at the end of the dialysis. Mother could not be. In the dialysis, my patient missed dialysis days over the past 2 months, and the activity of daily living, it was not impaired, and he was not on a proper follow-up. And course of the disease is complicated in the form of a failure to thrive, anemia, and signs of volume overload. However, there was no history of we were no history of headache as well as bony deformities. And with the treatment taken, there is no history of bad taste as well as headache. And uh, my patient was born by SPD at term with immediate cry with no postnatal admission, but immunization history and developmental history was insignificant. He is born to unrelated parents. He was a routine diet on adequate calories, and is well aware of the salt of restriction as well as restriction of the bananas and restriction of the bananas and dairy products, but they are not compliant to it. He is born to unrelated parents. First in the order of three siblings. Other siblings are healthy. The patient belongs to a family of low socioeconomic group. Father is a worker in a cloth shop and lives in a joint family in a three-malla house. And the expenses of the disease are being met by themselves, also by as well as from the relatives, close relatives. The disease is a significant impact on the family financially and psychologically, as well as upon the child in the form of missing school days. And mother has mother is concerned about the well-being of the child and has not been told about the renal transplant as well, and has poor knowledge about the disease.
Okay.
And this is a history examination. My patient is conscious, cooperative, well-oriented in time, space, and person, with no obvious respiratory distress in facial dysmorphism, having IV cannula in the left forearm, and also a central venous catheter in place in the right side of the neck, and also Foley's catheter in place, containing 200 ml of urine volume. His vitals were heart rate was 90 per minute, regular in rhythm, volume, and character. BP was 110/70. Temperature was 98 degree Fahrenheit. Respiratory rate was 18 per minute, and his height is 132 centimeter, and weight is 22 kg, which seems to be which is less than fifth centile. He is pale, having having a surgical scar mark at the lower spine, also having pedal edema. However, there is no jaundice, lymphadenopathy, cyanosis, clubbing. Uh, and his gait is normal, and intermalleolar distance is 1 centimeter, and the CVP line is in the right internal jugular vein with no overlying the discharge, sinus, and swelling, and abdomen is soft, non-tender, and protuberant with umbilicus centrally placed, and with no visible pulsation, scar marks, and stria. And there is no visceromegaly and evidence of fluid in the abdominal cavity. There is evidence of free fluid in the abdominal cavity in the form of shifting dullness. Bowel sounds are audible. Lung fields are clear. Apex beat lies at the fifth intercostal space in the mid clavicular line. First and second heart sound is audible. And CNS examination was unremarkable. I would like to do the fundoscopy of the patient.
Okay. So you have done with your examination and history?
That's it.
Okay.
Yes, ma'am.
Is there any rash in your patient?
No, ma'am.
Okay. Did you tell us about the rash?
No, ma'am. I forgot to tell you.
Okay. How was the throat of your patient? What was the oral cavity condition?
Oh. Ma'am, oral cavity hygiene was satisfactory, so it was normal.
Okay. What is the hearing assessment of your patient? Is the hearing normal?
Ma'am, he was listening to my command, but I would like to do the formal evaluation.
Otoscopic examination was normal.
Ma'am, I didn't done that. I offered it. I didn't.
Okay, you didn't check it. Okay, all right.
Yeah.
Okay, you told us about the gait. That is quite normal. What about the tone, power, and reflexes?
Yes, ma'am.
They were normal.
Ma'am, it was normal. They were normal. They were normal.
What was the measurement of the surgical scar that was present on the back?
Ma'am, it was about 8 centimeter long.
Okay, it
8
was
centimeter long.
linear or curved? Was that linear or curved?
Ma'am, it was curved.
It was curved. Okay, why it was present? Which
It
surgical
was.
procedure has been done?
Ma'am, I think it would be meningomyelocele, and that would be. I think that would this surgical procedure has been done for that.
Okay, so it was diagnosed at what age?
Ma'am, it was diagnosed since birth, at infant age.
Okay, so the child who was having meningomyelocele, you're suspecting normal gait and normal neurological examination.
Ma'am, the operation has been done, so the
Okay,
gait
what is
was
the
normal. According to my examination, it was normal.
gait was quite normal.
Yes, ma'am, gait was normal.
It was operated at what age?
Ma'am, 3 months. 3 months.
Okay, all right. Okay, so why your patient is catheterized?
Ma'am, for urinary incontinence, he has urinary incontinence. That's why he's catheterized.
What is the reason of the urinary incontinence?
Yes, ma'am. Sorry.
What is the reason of the
Sorry,
urinary
ma'am.
incontinence? What is
Ma'am,
reason
a
of urinary
neurogenic bladder.
incontinence?
Neurogenic bladder after the neurogenic bladder. When you operate the meningomalocele, there is a risk of neurogenic bladder. So neurogenic bladder was the reason.
Bladder was palpable or not?
No, ma'am, it was not palpable.
Bladder was not palpable.
Yes, ma'am. Yes.
Okay, all right. So why abdomen is protuberant in your patient?
Then there was ascites. That's why.
Okay, what is cause of ascites? What
Ma'am,
is cause of
cause of
ascites?
ascites. Ma'am, volume overload, because the
No.
patient was in heart failure. He was in the case of chronic kidney disease due to volume overload. That's why he was having ascites, body swellings.
Is there any sacral edema present?
No, ma'am, sacral edema was not present, but pedal edema was present. It was extending up to the shin.
Okay, was that pitting or non-pitting?
It was pitting.
It was pitting edema.
It was
Okay.
pitting edema. It was pitting.
Is there any bone pains in your patient?
No, ma'am.
Bone pains are not present.
Continue. Okay.
Okay. What is the cause of the fever in your patient?
Ma'am, I think a urinary tract infection,
What are the
because
features
he
of
was
that?
having decreased urine output.
Yes.
He was having decreased urine output as well as having burning micturition along with fever. So I believe that urinary tract infection will be the cause of fever.
Okay. What are the points which are in favor of the hypertension that is present in your patient on your history?
Points favoring points favoring of hypertension.
Yeah.
Ma'am, chronic kidney disease.
Okay, so what points on the history you have asked to rule out this
Headache.
is
Madam, for headache, I have asked about the headache.
okay? Is there any blurring of PN?
Ma'am, I didn't ask, but I only asked about headache.
Why did you ask for polyuria and polydipsia in your patient?
Ma'am, for nephronophthiasis,
Okay. Which antihypertensive your patient is
to
taking?
rule it.
Which antihypertensive your patient is taking?
Amlodipine.
Okay.
Amlodipine.
Which side effects you have asked in your patient about this amlodipine?
I asked about the facial flushing as well as the headache. Both were not present.
Is your patient ever advised about the growth hormone?
No, ma'am.
Okay. Is your patient having any time erythropoietin in his treatment plan?
Ma'am, he was having an injection at the end of the dialysis. So I believe that is subcut. So I believe that erythropoietin would be the injection.
Any medication for the treatment of the acidosis and the bone disease in your patient?
Yes, ma'am. He is having vitamin D tablet supplementation along with phosphate binders.
What
And
is
also
blood?
Sudamint he's also
Okay. What is blood group of your patient?
ma'am, I did not ask.
Who gave the blood when the blood was transfused to your patient? You told us like one time blood transfusion was done to your patient.
Ma'am, yes, ma'am. Yes, ma'am. Yes, ma'am. His cousin has given it. Cousin.
Okay. Was that properly screen matched?
Yes, ma'am. It was properly screened and it was transferred in tertiary care hospital.
Why did you
Uh,
ask about the ear discharge in your patient?
And to rule out the cause of
Okay, all right. What is your diagnosis?
ma'am, my diagnosis is it's a case of chronic kidney disease with complication in the form of volume overload.
Volume overload. Okay, what is your differential diagnosis? What is the cause of the CKD in your patient?
Ma'am, the cause of the CKD in my patient is neurogenic bladder. Neurogenic bladder.
Neurogenic. Okay,
Neurogenic bladder leading to VUR, vesico-ureteric reflex, resulting in chronic kidney disease.
okay. Any other differential in your mind
Based upon my presenting complaint, ma'am,
about your patient, your
or
CKD?
about your patient, CKD? No, ma'am. This is the only differential, I think.
Can this be a case of renal stones?
Ma'am, it could be the case of renal stones, but I didn't get the history of passage of gravels in the urine, as well as no abdominal pain, as well as vomiting or hematuria. So less likely.
Okay, how will you investigate?
Ma'am, I will investigate in the form of specific investigations and some supportive investigations. Specific
Mhm.
investigations uh, is RFTs, renal function tests, and ultrasound KUB. And for etiology, micturating cysto urethrogram, as well as DMSA scan. And for sportive investigations, I will advise chest X-ray, ECG, and echo, and CB, complete blood count, arterial blood gases, and bone profile, and uh, these are the investigations.
Okay, any other investigation?
Ma'am, to look for urine complete examination as well.
Exactly.
Urine complete examination, for urine
Any,
complete examination, urine for culture and sensitivity.
okay, any other
And
investigation? Would
any other
would you like to
investigations?
go for blood culture?
Renal biopsy.
Renal biopsy, okay. Any other
G, ma'am, blood culture?
investigation?
Yes.
Yeah, would you like to go for that?
Blood culture? Yes, ma'am, blood culture. He was having fever.
O- Okay, any other
Blood
investigation?
culture. Any other investigations to rule out the other etiologies? Well, it was not present in our case, but only
Okay, so this is all from your side.
yes, ma'am. Yes, ma'am.
Okay, would you like to go for serum electrolytes?
Oh, ma'am, yes, Serum electrolytes, yes. Serum electrolytes.
To go for
Serum.
formal hearing assessment of your patient?
Formal hearing assessment. Sorry, ma'am, if he was listening properly.
Okay, he was listening to you properly. Okay, all right.
Mm,
You'd like to go for the culture of the line that has been passed in your patient?
yes, ma'am. Tip of the culture. Yes, ma'am. Culture tip. Tip of the culture. Fine.
Okay. How will you manage?
I will review. I will counsel the. I will confirm the diagnosis, and then counsel the parents regarding the disease course progression and management. And I will involve multidisciplinary approach. And I will solve the acute problems as was the patient was my volume overload. So I will advise hemodialysis, and then I will look at the HP of the patient. If it is below par, I will advise blood transfusion, and then I will do the very chronic. I will do the chronic management options in the form of prescribing the soda mint tablet to my patient, and for iron, folic acid, and vitamin B12, and even its supporting injections for anemias, and for renal osteodystrophy, I will advise. I will give vitamin D supplementation along with the low phosphate binders, and I will also treat the underlying cause as it is a neurogenic bladder. So I will treat it, and I will advise nutritional rehabilitation, and I will in the final prepare the patient for the renal transplant.
Okay. So how will you manage this? The blood pressure of your patient comes out to be 200 by 170. How will you manage that?
Yes, ma'am. Ma'am, by giving calcium channel blockers,
Calcium channel
nifedipines, they are given nifedipines and hydralazine in
Okay, so
emergency,
will you give
hypertensive
refinement?
emergency. It's an hypertensive emergency. Then labetalol as well as nifedipine. Yes, ma'am. Sorry.
Yes, yes. How will you give that?
Yes, sorry.
You will
Uh,
manage
ma'am,
blood
it's
pressure 200 by.
ma'am, ma'am, by infusion, we will give an infusion of it, and we will try to reduce the blood pressure for 1/3 in 6 hours, and remaining 1/3 in next 48 24 hours, and the last 1/3 in next 48 hours. In 3 days, we're gonna manage it. But
Okay,
initially, we'll start with the infusions of it.
okay, all right. Would you like to go for the X-ray of the wrist joint or any radiological feature in your patient investigation?
And the patient was not having bony pains, but for the complication, to look for the complication, I can go for it. I can go for the X-ray instead. For bone age, for sure, let's look for the for bone age. Yes.
Okay, चलिए ठीक हो गया. Okay, how would you differentiate this is nephrotic and nephritic syndrome? If it is a case of nephrotic and nephritic, what are the points which are in favor of nephritic syndrome in your patient?
Ma'am, hypertension and hypertension and body swelling. These are the features of nephritic, and in nephrotic, the patient is having body swelling only. So
Okay,
there
what
was
are
no
you?
hematuria
There was no
in
hematuria.
history. Yes, ma'am.
Okay,
Sorry,
what
आवाज
you are
कटी है?
expecting on the what are you expecting on the renal biopsy findings?
In ma'am, in my case,
Yes, definitely in your case.
yes, ma'am, tubulointerstitial fibrosis.
Okay, so you are suspecting tubular
Tubulointerstitial
infiltration.
fibrosis.
Okay, can this be a case of drug-induced nephritis?
Uh, yes, ma'am. Yes, it could be, but there was no history regarding the intake of the drug. It could be the case of it.
Did you describe about there is no history of drug intake?
I've told it in my history there was no drug intake.
ओके चलिए ठीक हो गया डॉक्टर उमैर, जिस मिनट में आपकी रिकॉर्डिंग
जी जी